Good afternoon, everyone. I'm very happy to be here. I'm Senosiain from Bogota, Colombia, and a cardiovascular surgery fellow. I'm going to present this case, retrograde type A aortic dissection, the other phase of endovascular management in aortic arch aneurysms. So I have no disclosures. The case presentation is a 75-year-old male with multiple comorbidities, including COPD with 24-hour oxygen requirement. He was diagnosed with distal aortic arch aneurysm of about 55 millimeters, asymptomatic. The transthoracic echo showed an EF of 63% and aortic root for about 42 to 43 millimeters with a normal aortic valve. This is his initial CTA. We can see the aortic arch, the aneurysm. You can see it with the arrow. It's before the left subclavian artery. The diameter is 56 millimeters and it's 7.5 centimeters long. This is a 3D reconstruction where we can see the anatomy I just told you about and the planning we were going to do with this patient and the graft we were going to use in this patient. Please take note of the ascending aorta right now. Before the procedure is about 38 millimeters, so that's very important. You know that the traditional treatment is open. You have to do a sternotomy, right axillary cannulation or innominated artery cannulation. You have to give the patient hypothermia, extracorporeal circulation, and circulatory arrest. The results of the open repair, it's high. The early mortality is from 5 to 16%. Stroke is up to 14%. The spinal cord injury is 5%. And these are results in centers of excellence. So the aortic arch aneurysm is infrequent. It's about 4% of all aortic aneurysms and is usually in association with ascending or descending aortic aneurysms. So in high surgical risk patient, like our patient with the COPD I just told you about, they benefit from endovascular management and also if they have favorable anatomy. So this was the device we were going to use for the procedure. It's a 2-branch aortic arch device. The first procedure we did is a left carotid to subclavian bypass. This is the photo of the surgery. After that, these are all the incisions we made. We did a right cervicotomy, left cervicotomy, just before we did the bypass I just told you about. And the pictures below are the axes we got in the femoral arteries and vein. So the second step of this procedure was to deploy the main stent or the main graft in zone 0 of the aortic arch. So this was made with a pacemaker so that we can put it just where we want it to. The third thing we did is put the first branch of the device right from the right carotid artery. So this is the angiogram while we were doing that. We did use IVUS in order to know that we were in the place that we needed to be. Yeah, of course. After that, this is the final angiogram of the first branch. After that, you have to put the second branch through the left carotid artery. So this is the final result of that. And after all that, we extended the correction with a T-bar, and this is the final angiogram. This is all the team that were in the procedure. We invited a vascular surgeon from America to help us because this was our first procedure. So it was pretty big for us. The results were excellent. We get 3 days at the ICU. He got 1 episode of atrial fibrillation. That's why he spent 3 days in the ICU. And 6 days after the surgery, he was discharged home. The idea was to make a CTA control 1 month after the procedure. We saw the patient 1 month and 3 months after the procedure. He was asymptomatic. We constantly asked him to perform the CTA, but he didn't because, well, I don't know. So, yeah, I really don't know. But after 1 year, I was calling him myself, calling him, like, please do the CTA because we have to know how is everything. So 1 year after the procedure, the patient reported that he was with intermittent episodes of chest pain associated with dizziness. This is the CTA where we can see a retrograde type A dissection with a type 2 endoleak. And as just like I told you about, the ascending aorta is now 6 to 7 centimeters with an aneurysm and with the obvious type A retrograde dissection. So what to do now? It's a very difficult case. So we discussed this with all the group and all the heart team in our hospital, and we decided to do surgery. What we did an ascending aorta repair with a dacron graft 30 millimeters from sinotubular junction to the previous endograft. We did central cannulation with via right axillary artery, femoral artery, and central venous via the right atrium. We get the patient to moderate hypothermia, antegrade cerebral perfusion, and we used an aortic endoclamp because of the stent that we previously put. The results were very good. He went to the ICU for 2 days, discharged 5 days post-op with satisfactory evolution, and this time we get the CTA control in the hospital with an adequate repair with no endoleaks. So this is the, can I go back? Sorry. This is the final CTA. So in conclusions, the endovascular repair of distal aortic arch aneurysm is a therapeutic option in elderly patients with multiple comorbidities and favorable anatomy. Main complication is stroke and the presence of endoleaks. The retrograde Stanford A dissection is a rare but catastrophic complication. Patients require strict follow-up with strict CDAs controlled, and it is essential to know this entity, the risk factors, clinical presentation, and to have a multidisciplinary team prepared for its approach and treatment. Thank you.